uh, joining us from different parts of the country at various capacities, both public and private sector. So I understand this is the right audience that we have to talk about today's topic, a part of it probably. So I would like to welcome, we have three faculties for today's discussion, and we expect more of interactive session from you all, from the participants. We expect you to ask your questions, clear your queries today.
Dr. Sridevi, is there a slight echo kind of rolling sound from your end?
Okay, how is it now?
Better now, ma'am, better.
Okay. So we have Dr. Rajani. I'll introduce Dr. Rajani first because she's going first with the session. She's a consultant pulmonologist at Sparsh Hospital, Bangalore. She has done her MD internal medicine from New York, followed by pulmonary disease and critical care medicine from New York. She has she has also done her national fellowship in palliative medicine, which is a one-year fellowship done in Kerala. So she is a strong advocate for palliative care and pulmonology integration across the settings. Welcome, Dr. Rajani, to today's session. Raju, can you show the next faculty slide? So another speaker for today is Dr. Raj K. Mani. He is the Director of Clinical Services, Pulmonology and Critical Care, Yeshwada Hospital, Ghaziabad. He has an internal medicine with he has immense years of experience in ICU, critical care and pulmonology. Now he talks a lot about ICU and palliative care, and now people always ask about the legality, the ethics, and do's and don'ts and everything. I think he's the right person to talk about it. He was a former president of Indian Society of Critical Care Medicine, and he's worked in collaboration with IAPC to bring out position statement on its working with Droid life cycle. Thank you, Dr. Raj, for we just met 2 days back in another session. So this is a very different group of people we'll be hearing from you again. The third faculty we have with us is Dr. Dhvani Mehta. Dr. Dhvani is co-founder and lead at VT Center for Legal Policy. And she has done an immense work in Supreme Court of India in common cause versus Run of India. She was a part of expert committee for do not attempt resuscitation. And all of them have done a lot of work in what we talk a lot these days, and where people are confused or lost or want an opinion from experts like you. So I welcome three of you for today's session and welcome all the participants. I think Dr. Rajani will be starting the session. She will be joining us soon, Raju. She's already joined.
No, I think we are waiting for her to join us right now.
Yeah, maybe a minute. She told she's just reaching back. Yeah.
Yes, she is there.
Yeah, you appeared at the right time, Rajni. I was just saying she's joining soon. So thank you so much. Over to you.
Rajni. Hi, Dhvani. Hi, Rajalakshmi, others.
Hello. Nice to see all of you. My apologies. I will just quickly get, is it time for me to get started?
Yes.
Yes.
I will just set up my slides. Just give me a moment.
Der aaye, durust aaye.
Just it's also giving me warnings that I need to charge my laptop. So forgive me, I will just very quickly take a second to do that. Good evening and welcome to today's session on palliative care in the ICU for patients with pulmonary disease. And I know that you've all had a whole bunch of wonderful sessions on various other aspects of palliative care for patients with pulmonary disease. Now, today we are going to be discussing some parts of it which might seem counterintuitive when you think of intensive care and you think of palliative care. Traditionally, most people have thought that they are two completely different areas of clinical care. That if a patient is going for intensive care, then that's not a patient who's on palliative care, or if a patient is declared to have palliative care involved in their overall treatment, then that patient is not one who is going to the ICU. But there's so many more dimensions to integration of palliative care in the ICU, and especially so for patients with pulmonary disease. So, the problem of respiratory disease is very, very high. And oh, I'm sorry, I am just going to change this one. Just give me 1 second. My apologies again. All right, my apologies for the tech troubles at the start of today, but I'll try and catch up to time. So our problems have been about the seeming the idea that these two aspects of care, critical care and palliative care, cannot go hand in hand. However, this is something which, at least in our professional bodies, we have acknowledged for a very, very long time, for decades now. The earlier concept that curative or restorative care was the first part of the onset of disease, and it's when you can't offer anything else that palliative care comes in. That concept is now outdated. And even the official statement of the American Thoracic Society and the European Respiratory Society, every professional body now clearly includes palliative care as something that runs concurrently. So if it's running concurrently from the time of diagnosis, I'm going on beyond the time of death, going on to bereavement, then very clearly palliative care is also included in intensive care when a patient is in the intensive care unit. So the guidelines for recommendations for end-of-life care in the ICU is actually something that the professional bodies across the world have spent a lot of time to build consensus around. And one of the very robust statements that came out of it, and I know Dr. Mani was also part of this group, was in 2014 with the consensus for worldwide end-of-life practices for patients in intensive care units. And the idea really was about bringing some sense of evidence, good practices, best practices, which is ethical and the best of clinical care for a patient. Similar to this, there's also been developments in India after the Well-Pickers 2014 consensus statement. And there was a combined statement, position statement of the Indian Society of Critical Care Medicine, Indian Association of Palliative Care, and the Indian Neurological Society, where basically it talks about a position statement of these bodies on what is the right way to plan for end-of-life care of patients in the ICU. There's been a lot of ambiguity that people have had during their training years about how does one incorporate end-of-life care in the ICUs, and notions about withdrawal and withholding life-sustaining treatment. These are things that have not been clarified for us in our training years. All of this is now much more robustly outlined, much better supported by law, and you're going to hear from the experts who've led the change right from the front with Dr. Mani and Dr. Dhvani Mehta later on in the course of the evening. So it is clearly emerging, end-of-life care in the ICU is clearly emerging as a comprehensive area of expertise in the ICU. And it demands the same level of knowledge and competence as any other area of ICU practice. So if we know how to manage a type 2 respiratory failure, we know how to manage a diabetic ketoacidosis, we know how to manage a stroke, we should also know how to manage end-of-life care in the ICUs. Specifically for pulmonologists, many of our patients have conditions which are going to progress. Some of them will opt for their end-of-life care to be in their homes or in the hospital in a supported environment. Some of them will even be in the ICU. We may come across patients with the advance of certain medical therapies that are available, such as lung transplant, who have end-stage lung disease, who have ILD or bad COPD, who will be on multiple life support systems. They could be on ventilators or ECMO in the ICU, and maybe they end up in a situation where their symptom burden is very high, the care is complex, and they will require the expertise of either a palliative medicine consultant or the pulmonologist to exercise their primary palliative medicine knowledge in order to provide the best care for that patient. So what do we know so far? We know that since 2008, since 2014, there have been recommendations and position statements by all professional bodies saying that palliative care is essential for patients with these kind of end organ failures in the ICU. But we still find that referral to palliative care doesn't happen so much from the ICU. So when you look at different specialties or different diagnoses that the patients come in with, so when you look at patients who have a diagnosis of cancer, many of them, when they're admitted to an ICU, for whatever it might be a neutropenic sepsis, but they would have had many other symptoms which warranted a palliative care consult. Invariably, what ends up happening is that palliative care is called in at the very last minute. It's as if to say, I want to declare this patient DNR, so come and do that difficult conversation with the family. However, as pulmonologists, if we are the primary doctor for that patient, we are the ones who have a better chance of understanding what the patient's symptom burden is, what their thought process are, what their values are, what their goals of care are, and be able to provide the right kind of palliative care for the patients. And all studies so far say that lung disease patients fare worse than cancer patients in terms of getting adequate access to palliative care. So it's very important that we use palliative care not just to facilitate a conversation about ventilator or not ventilator, but also for alleviating the suffering of patients who have chronic pulmonary disease who end up in an ICU, because they have a very high symptom burden. They have pain, they have breathlessness, they may have constipation, they may have sleep disorders. All of these things also need to be palliated. So this is a huge gap despite the knowledge, the body of knowledge that exists in our country. And one of Dr. Mani's pet peeves, I know, is that when we don't have the expertise to deal with these complex situations for patients, very often what has happened is that, if you're not willing for ventilation, then you go LAMA or DAMA. Or if the patient is on life support and the family's feels that, and if this now patient does not have a meaningful hope of recovery, then we do not offer withdrawal of life-sustaining treatment along with palliative sedation for alleviating breathlessness and discomfort. And the patient goes DAMA, LAMA, and ends up dying in a horrible way on their way home. So these are the areas, these are the gaps that we need to address, because we can't say in 2023 that we don't know how to do this better. Because at this point, we have the medical know-how and we have the support of laws that will help us as well. And you'll hear more about what's the right way to do things going forward. What are the barriers to implementing palliative care in the ICU? So we basically, it's a very complex environment when the patient is in the ICU. And this huge barrier is about the cultural acceptance of palliative care in the ICU, because of what we thought as the dichotomy, that if the patient is on intensive care, they are not for palliative care. If the patient is palliative care, they are not going into the ICU. So this is a huge shift in thinking. We need to do more training of young residents, young fellows, young practitioners to get systems ready and make palliative care an essential part of our care, not just a nicety in some places, or if a patient asks for it. It should be something we proactively offer to patients who have significant health-related suffering in the ICU. There's so many distressing symptoms that our patients who have chronic pulmonary disorders go through when they're in the ICU. So imagine if you are a patient with COPD or ILD and you are on 20 to 24 hours of NIV, and there's a central line. There might be other catheters in your body, and you are maybe NPO because they're worried that if you eat something that you might aspirate. So you're going through pain, breathlessness, thirst. It's an alien environment. The lights are on all the time. There's alarms dinging all the time. So there's anxiety. Am I getting better? Am I getting worse? You're in a state of, you're slightly confused, drifting in and out of sleep. Every time you wake up, there's a crowd of doctors at the foot of your bed. They come flip through some charts, say some things to each other. Every now and then someone comes and just touches you, pats on you, says, "You're doing okay now." And it's so confusing. You're not able to speak because when you try to speak with the NIV mask, they're not able to hear you. You are losing energy just trying to communicate. This is the situation of our patients in the ICU. So we have to keep in mind what the patient experiences. What does it feel like for a caregiver to come in and see their loved one in that condition? So prepare them mentally when they're coming in to see their loved one. You will see them on a machine. You will see them with tubes. Don't worry, we are giving medicines to keep them comfortable. Come hold their hand. It will calm them down better. If they come in and they find their loved one restrained with so many tubes, it's the most distressing sight for them to see. So communicating well with the patient, involving the family in helping us with the patient, so many ways that we can alleviate the distress of patients in the ICU. So what are the things that we need to keep in mind? It's always very difficult if it is a sudden illness, right? If someone was perfectly fine and then they had some kind of an episode which was like a near drowning or some inhalational injury, and then they have respiratory failure, and then they end up in the ICU. That's very different from an ILD that is advancing patient on a transplant waiting list, and then who's getting worse, who has exacerbations every now and then, may have multiple ICU hospitalizations. A patient who's not a transplant candidate may still be okay with the idea that I will set a certain ceiling of care. I do not want to be intubated, but if it's high flow nasal cannula or if it is non-invasive ventilation, I am okay with ICU care. So even if it is severe sepsis, give me a time limited trial of ICU care. Give me 4 days in the ICU. If I'm not turning around on the 5th day, let's have a conversation and maybe I come out of the ICU to be with my family. So if it's in sudden advanced illness, yes, we do not have prior knowledge of the patient's wishes. But if we have been taking care of a patient and they've had 1 or 2 hospitalizations in the last 6 months or 1 year, then I definitely need to know, hey, you got sick last time and you were admitted. What if it gets worse next time? Have you thought about it? So having these conversations, if the patient has advanced progressive respiratory disease, we need to know about their wishes. We need to know their goals of care. We need to know that what is the ceiling of care. Don't go beyond this. Do up to this, but no more. So that is still intensive care. And that is also palliative, right? You're palliating their breathlessness and you are trying to reverse what is reversible. In principles of palliative care, we always try to reverse what is reversible and support all the distressing symptoms that we possibly can. So making emergency plans for the patient, helping them understand all these potential options that they have. It's not all or nothing, ICU or no ICU. ICU, time-limited trial, hospital-based, high-flow nasal cannula in the ward. All of these are options that we can explore. When we are having these conversations with our patients, it's very important that we base our conversations on the 4 pillars of medical ethics, where we tell them as best as we can the prognostication. We have certain tools available to us. When you look at GAP scores and COPD, when you look at, what severity of COPD they have, the number of exacerbations they're having, these are things that help us predict and prognosticate. One of the most consistently well-performing markers on this is something called the surprise question. So a clinician who's known the patient for long, it could be a pulmonary care nurse, it could be the person who's seeing the patient in clinic on a regular basis. If you ask them, would you be surprised if this patient were not to make it in the next 1 year, if they were to die in the next 1 year? And if the answer is no, I would not be surprised. That's a very strong prognosticator. So when we keep in mind that we base it on what the patient's clinical condition is, based on the best knowledge available to us for prognostication, and we communicate it in a compassionate manner and try and elicit what the patient's wishes are. And if they are not able to, even patients who have, we sometimes have patients who have certain kind of mental, either a mental disorder or mental health disorder or limited cognitive function. Even those patients have the same rights And if you can explain it to them in ways that they understand the pros and cons, shared and supported decision making is what we need to try and aim for at all times. We will base it on good of the patient, not doing any harm, always keeping autonomy as a very strong guiding North Star. And here then we understand if the patient's wishes are such that, sometimes the actions that we take, if it is about alleviating breathlessness, use of opioids or benzodiazepines, this may also lead to certain downstream effects which may hasten the process of death and dying. But our primary intention is alleviation of the patient's discomfort. And so when we are looking at the application of all these principles, what we're looking for is building our understanding of how to apply these best practices repeatedly over and over in our systems. So especially in the ICU, when we are trying to apply the ethics of these complex decisions, it's about articulating it every time we go over the decision. So if I am the clinician in the ICU and I'm communicating with the nurses, the respiratory therapist, the junior doctors in the ICU, that these are the principles on which we are making this decision for this patient. It will also help them in understanding, and it will translate into the action that we're looking for, which is earlier palliative care involvement of the patient. Doesn't necessarily mean a specialist palliative care consult. It could be the pulmonologist or the intensivist wearing their palliative medicine hat and applying the palliative medicine principles of care for that patient with advanced progressive respiratory disease in the ICU. So, in fact, there are plenty of wonderful documents now that can help support us. And these documents will help clinicians to support in terms of assisting in, ethical end-of-life care in ICUs. The Blue Maple document is one, and I'm going to share it with Rajalakshmi to share with all of you. This FICCI document tells about how hospital administrators, so if you are a unit head and you're speaking with hospital administrators, and your hospital administrators are telling you that this is not possible, these are the documents that can help us to convince our hospital systems on how to mature and progress on the right track of ethical and involvement of palliative care and end-of-life care in the ICUs. So these are the different models of care that you can adopt. If you have a palliative medicine specialist available who can consult for the ICU, that's one way of doing it. Or there are institutions like in Mangalore, where Dr. Naveen Salan's team, I think they have a round in the ICU once a week. So that's an integrated model of palliative care, where the palliative care team is embedded within the ICU rounds every week and consult on patients who have complex palliative care needs and symptom burden. And the other model is nowadays with telehealth, considering that there's a shortage of palliative medicine specialists in our country. We can always seek the expertise, especially in a post-COVID-19 world. We have access to far more specialists who may not be able to come physically for rounds and things. So how do we measure our success on this path of incorporating the best quality care in our ICUs? It's really about getting to know the patient and what matters to the patient, rather than just looking at a patient as a combination of multiple clinical diagnoses. This was a photograph of a gentleman who had severe COPD. This was shared by Dr. Wes Eli on Twitter. This gentleman had severe COPD, had failed multiple attempts at weaning, had had a tracheostomy done at one point, and he knew that this is not the way he wanted his end of life to be. He was like, I don't want to be on the machine. I want my wife by my side. I want a cold beer, and I want to be allowed to go in dignity. And that's exactly what the ICU team did when they realized that his lungs were at a point where they were not going to be able to get him out of the ICU without a ventilator, with any quality of life that meant a lot to him. So for his breathlessness, they offered him palliative sedation. His wife was by his side. They made sure that he could pop open a beer and sip just a few sips along with his wife. And the whole team was there to support him in making sure that what mattered to him at the end of life was made available to him. And that's sort of what we have to do, that even if we are not able to come out with an outcome which is return to a meaningful quality of life, even if it is that a patient's life ends in the ICU, what really matters is what lives on in the memories of the people that they leave behind, as Dame Cicely Saunders said. So if the end of life, even in an ICU, is with a measure of dignity, it's with comfort and relief of all symptoms, it is with support to the bereaved caregivers, then we have done our job as intensivists, as palliative medicine, integrated palliative medicine practitioners within an ICU. So with that, I've shared a couple of images of patients who've left an indelible mark on my heart because they've taught me how to apply these principles for them in ICUs and at the end of their life. And I'll stop there. Thank you. And I apologize for the delay again.
I was wondering, we can have all the questions in the end. We can take the questions.
Okay, Rajashri, I'll then share.
Sure.
Okay. Oh, all right. So today's talk is about coming together to humanize critical care. So PAL care is what? It is not a alien specialty. It's a specialty that is essential, I think, to all specialties. See, Marcel Proust, you might have heard of, he said, a voyage of discovery isn't exploring new lands. It is having new eyes. Okay? New eyes. So that's what we go to the bedside with new eyes to provide a more comprehensive care, more holistic care, more humane care. So I'll give you a real life story, okay, to put things in perspective. There's a 101-year-old holy man had a prolonged critical illness 10 years ago, following which he became wheelchair bound and dependent. A familiar situation. The age may not be the usual one, but the very elderly often have this kind of predicament. A pig that is, an orifice made in the stomach for those who are not in the medical field. So we do artificial feeding through that hole directly into the stomach. And the problem was he started to have fever, and which went on unabated for 6 weeks. So how did we respond? All cure, no care. Right? So this is what a cure and care coming together. I said two things coming together. This is what. Several courses of antibiotics, including colistin, right? One end of the spectrum. Polypharmacy, including levodopa, clonazepam, fluoxetine, sertraline, haloperidol, quetiapine, paracetamol, nimesulide. This often happens. We throw in everything we've got, okay, the kitchen sink, and don't reflect, only react to every symptom. Suctioning and respiratory physiotherapy was going on. See, when you talk to survivors, it's been done before, survivors of critical care, one of the most painful things is the suctioning, right? It's like putting a hot rod into the airway. Many things will be surprising. Pulling out an intercostal drainage tube or turning, right? And of course, all the loneliness, all the depersonalization. I will get to that. But suctioning isn't as banal as we caregivers imagine if you talk to the survivor. Now the same experience, the dying and and the terminally ill also experience, but they are not able to tell you afterwards because they're out of reach. So we must know what we are doing. Therefore, not every action for cure, but for care as well. So this is what we found at admission of 40 degrees C temperature, breathlessness and paradoxic breathing, heart rate very high with a irregular heartbeat, atrial fibrillation. Diaphoresis means a lot of sweating, anxiety, high oxygen requirement. So how do we combine cure and care? So this is what is needed, the added dimension, the new eyes that we must wear. So he was found to have ILD, interstitial lung disease, but that's gone into the background. Now the current problem is different. It's the serotonin syndrome. When you have a lot of psychiatric medicines, you may have this syndrome. So we gave intravenous midazolam. So first thing is to get a good diagnosis. Okay, combination of science and art. First the science. Get to know exactly, precisely what the problem is. Then the caring. IV midazolam, buprenorphine, clonazepam through PEG, bowel management, discontinuation of antibiotics. Discontinuation. Now you know the diagnosis. You don't have to use a shotgun. One bullet is enough. Support and education of caregivers, the family. Okay, talking to the family, what the experience of the patient has been, where we are heading, defining the goals of care, and then the shared end of life decision making. So our goals have been rescue in critical care. Has been rescue, big predominant value, and then to extend length and quality of life. What we forget is relieving pain and suffering is a very essential, fundamental duty of care, which we seem to have relegated to the background and not providing enough attention, nor are we getting well skilled at it. So let this be clear, as Rajani had mentioned so eloquently. Critical care and palliative care are not polar opposites. They are not to be applied sequentially. In the end, no. In the beginning, they're conjoined twins. They're integral to comprehensive healthcare. If you want to do a good job, if you want to be known as excellent for your excellence, then you cannot but look at all the dimensions of care. So you can see there's a concordance of goals between critical care and palliative care. They are not opposites. They only add to each other. They complement each other. So if the primary goal of critical care is saving or prolonging life, its secondary goal is also alleviating suffering and improving quality of life. But in palliative care, you reverse this. The primary focus is on alleviating suffering, improving quality of life, but it doesn't mean you're not aiming at saving or prolonging life. It's now well known by elegant studies that you may actually add a few months to terminally ill patients, going over to palliative care from the beginning. Okay, not waiting for the patient to suffer. Rajani mentioned this paper, Palliative Care in the ICU. This is a consensus document after thorough research of, it was published in 2014 of the existing literature, and then having a consensus on the way forward. How to improve palliative care in intensive care. So this is a diagram worth remembering. It's been very useful. It is from the Society of Critical Care Medicine, USA. It was also adopted by NICE of UK. National Institute of Clinical Excellence. So this is what it is. Curative care and palliative care start together. Then as we realize the trajectory of illness is not upward but downward, palliative care takes over. And progressively, palliative care takes over more and more of our attention. And then there is no disease-directed treatment at this point. It's taken over by end-of-life care, and caregiving doesn't end here. It goes beyond to bereavement and post-bereavement care as well. I'll give you this story as well, another story from my archives. Okay, a young man he was 30 years old, a little younger than that. So he was just standing beside his car, and when another car just came and ran over him, just ran over his pelvis and sped away. You know, the Dera Sacha Soda group. There he lay, well, then he was brought to me from very far off, from here, Punjab, he was brought to Gurgaon. And then what he had was this pelvic stabilization, as you can see. Everything seemed all right. Fortunately, his internal organs were not damaged. So we thought he had a good chance, he would do well. He had a pelvic fracture, that's it. But the next day morning, his BP fell into nothing. And his right heart was ballooned, and we knew he had a massive pulmonary embolism. That was despite a prophylaxis. So that happens. So it was then a huge war. Okay? All week. We gave him, of course, thrombolytic therapy. We also, of course, a lot of vasopressors. His lactate was right up to 14 or 15. Then this alone was not enough. We had to actually do a catheter-directed embolectomy. And then he went into renal shutdown. He had IVC filter as well because he had a retroperitoneal hemorrhage. So many things happened. So after a few days of sedation, paralysis, when he woke up, it was very difficult to control him. He was extremely anxious, emotionally charged. He would try and get up. We can't perpetually keep him under heavy sedation. So I just sat down beside him. I said, Pawan, tell me, what's bothering you? Right? What's going on? He said, मैं छोड़ूंगा नहीं उनको. Right? So you see, the human being is ill. It's not his pulmonary circulation that is affected. Its heart is affected as well, in the emotional sense. So he was just riled up in anger, in frustration, in the idea of being subjected to this suffering by some heartless and wanton and rash people. So part of our palliative care is a therapeutic conversation. So we had a conversation. I assured him he was going to live. I assured him he had a lot to live for. He had a wife and a child of 2 years. Reminded him of his child. Showed her photograph. He calmed down. Believe you me, we could wean him off very quickly afterward, off the sedation first and then the ventilator. So this is real, straight from as I had experienced. So palliative care should be integrated in any of these three models that Rajani had mentioned. Primary palliative care team, which wherein the ICU, the ICU team itself is skilled, is empowered and trained in these competencies. A consultative palliative care by a dedicated palliative care team, which doesn't just give expert advice, it's involved with every patient, right? And but a mixed approach is where both the teams work together. The ICU team and the palliative care team work together. In the consultative model, you need a lot of palliative care specialists. This country has very few. The mixed approach suits us best. Wherever the ICU care team needs, they ask for the palliative care consultation. In any case, it is the ICU consultant who's involved with the patient care who needs to take up this responsibility of building a relationship with the patient and the family, and then using that for care and therapy. In Spain, this idea of humanizing intensive care was very much discussed at a national policy level, and they took a lot of survey of various caregivers, and they identified 8 points to humanize intensive care. Open visiting policy, communication, well-being of the patient being the most important. What is of most importance? It is the patient interest. The most important interest is the patient interest. Presence and participation of relatives. Caring for the healthcare professionals as well. Caring for the carer with the equal kindness. Prevention, managing, and monitoring of post-ICU care syndrome. We all know that intensive care is a devastating experience and leaves a lot of physical, emotional, psychological trauma that carries on post-intensive care for weeks or months or even years. So humanize architecture, infrastructure in the ICU and in the hospital, and then end-of-life care, very important, where all your ethical dilemmas and challenges and your skills come into play. These are the causes of suffering and possible solutions identified in this Spanish document. Pain, thirst, temperature, noise. There's noise going on 24/7. You know how nerve-wracking that can be. Lack of sleep and rest. Fear of what's going to happen. Fear of the unknown. Loss of speech and loss of means of communication. Loneliness. Lack of information, so uncertainty, inability to move. Okay, movement is so important. You feel so helpless, so depersonalized, so out of control. Loss of identity, discomforts of various forms, loss of dignity, dependency on machines, and machines noise all the time, lack of a sense of time. They lose a time of day and night, lack of understanding of what to expect. There was a wonderful report by the Lancet Commission on the Value of Death. Libby Solnow and others. It's a massive work, okay, bringing out the intersection of whatever life is, right? The humanities, the science, the economics, the environment, the cultural, right? The cultural side, and also the policy and legal side that impact on our dying and grieving process. So in the ICU setting, dying and grieving has to be managed with skill and understanding, An ethically grounded practice is what is required, and it's best tested in the context of EOLC. So we need attention to ethical principles, communication and palliative care skills, legally informed practice, community participation, as exemplified by Dr. Rajagopal's pioneering work and national policy. Randall Curtis is a big name in ICU palliative care, pioneer. Since the early 90s, he has been working. He had been working. We unfortunately lost him in February this year. So he wrote this editorial recently, before his death. This had been published. There's an ecosystem of national culture, policy, institutional policy, individual physicians and family. Right? So all this impacts on the way you manage end-of-life care. This construct is very much applicable to our Indian conditions. Our national policy and national culture is not evolved enough. Institutional culture is also very much behind times. And then clinicians have their great biases and fears, fear complexes. Patient and family are uninformed about death and dying issues. It needn't be like that. We can prepare well. This is a terminally ill patient, she's smiling, right? Because she's with her children who had come from different parts of the globe. They are with her. So not being alone, being with a loved one is very, very important. And that can't be done if you don't prepare well. You don't disclose properly the prognosis. You don't discuss the prospects. You don't discuss the possibility of death and the preferences, the choices, right, of the patient. If you can directly communicate with the patient, or via the family, you gather what the person is. Another one like this, terminal cancer. He's not alone. He's also smiling. Why? He's got all his grandkids. Eh? So they are smiling. They are not morose. So you don't have to wait for death with a long face. When you're well prepared, you will be surprised how pragmatic people are and how they adjust to the new realities. So communication is crucial. There was a time in the late 19th century when the doctor would sit beside the patient like this in an overnight vigil when this child was dying. It's a painting of the late 19th century, I think 1998 or so, 1898. But then cut to the modern times. Slide I borrowed from Rajani. Look at it. His attention is glued to the LED screen. Away, completely away. There is no body language of care. This is very important. Non-verbal communication, body language, your attitude, your interest. So my associate clicked this picture unknown to me because I was talking directly to the patient. It's possible. Even in critical illness, you can connect with the patient, talk directly, discuss his preferences. It's possible. It may not always be possible on the first go, but you build a relationship and build a trust, and it's possible. Of course, most of the time you have to talk to the family, and then this is a very crucial intervention. Don't say we don't have time. If you have a problem putting a central line and it takes you 1.5 hours, you do it. Don't you? You don't wash your hands off and go away, walk away. If you have a difficult intubation, you still can do it, take more time. This is an intervention of even more overarching importance. So this must be done. It must be done properly. So the legacy of interprofessional family meeting, again written by the icon of ICU palliative care, J. Randall Curtis. So have a communication, start connecting with the family within 24 to 48 hours. Open up proper conversation where you can build relationships, where you can address emotions, when you address queries, when you can start to work with them on the disease, its prognosis. There's a lot of uncertainty in the intensive case. So you work on a certain baseline information, and then you build up the information. Please factor in uncertainties. And it is very often you speak a lot and the family listens, you occupy all the time, but you don't listen to the patient, and you don't know what the patient or the family has absorbed, has understood or interpreted. So therefore you must ask, tell, ask. First ask, would you know? May I share with you information? Then you tell them. And then you ask again what you understood. So this happens in every conversation, every session. And we must use words very carefully. That is, empathy is expressed by acknowledging emotion, by using words that don't jar, that are sensitive. At the same time, they are honest. So you identify the emotion, scary, stressful, sad, or angry. Acknowledging emotion is therapeutic. Using conversations as your therapeutic tool and diagnostic tool, you go through this algorithm for clinical decision making. If there is an advanced will, then you work with the identified professional, and then you honor whatever wishes the patient might have expressed to the extent it is concordant with the best standards of practice. Then you, if you don't have advanced medical directive, as is the case in 99% or more, you work with the next of kin or surrogates or next friend and make honest disclosure of terminal illness prognosis and the inappropriateness or appropriateness of any life-sustaining intervention, and then negotiate a ground in which you can consider DNAR withdrawal or withholding. And in case of conflict, you wait and work through it, negotiate through it. In case of unresolved conflicts, you may take second, third opinions, or you may go to the board, a clinical board, ULC board in the hospital. Ultimately, you don't want to get there. In real conflict, you approach the court. The ICMR had already given us this document, consensus guidelines on DNAR. So DNAR is not something only happening in the West. It is very commonly needed in our midst. 95% of CPR is going to be useless in the ICU and may be very harmful. Firstly, it's an undignified death. Secondly, you may get to a fate worse than death. That is severe neurological injury, which is a huge drain on the resources of the hospital and of the family and the nation. After 2018 judgment, we got a constitutional validity of advance will and withdrawal withholding. Dhvani will talk more about it in detail. So, to our great relief, we got this simplification of the SC guidelines in January this year, and we could get a legal guideline for executing withdrawal withholding decisions. Dhvani will elaborate, but suffice it to say it is now doable, and we must take it from this point actually use it in our practice, and it can get more tweaked and simplified as the needs are become apparent. So I would like to end here saying that we seriously need a change of culture in which we shift to a perspective which cares for the whole person. Okay. Not just a physiology, not just a bodily function or structure. Integrate the palliative care principles throughout the disease trajectory, not just in the end, as per the SCCM guidelines. Walk the talk about the patient and family-centric care. We talk a lot, and we must show it in action. I would say it should be a human-centric. We should also care for our colleagues. We must care for our own mental and physical health. Then it will be a culturally different environment. It will be humanizing medicine. Thank you very much for your patient hearing.
Thank you so much, sir. I think we'll quickly go to Dr. Dhvani, and then in the end, we can take up the questions and the interactions together so that three of you can take the questions. Over to you.
Sure. Thank you. And thank you so much to Dr. Rajani and to Dr. Rajmani. I'm always inspired by how they speak, and I feel bad that I have to follow them with this very prosaic discussion of the law. But nevertheless, I will let me share my screen as well. I have a few slides on what the current legal framework is, how we got there, and what are some key points to remember. I'll keep my discussion brief because I'll keep my talk brief because I tend to know that perhaps more questions come up in the Q&A, and I'll be very happy to take those when, whatever questions everyone might have. So I just thought I'll give you a brief overview of what the legal journey towards recognizing the right to dignity and the right to refuse medical treatment has been. There has always actually existed a right to refuse medical treatment, irrespective of whether we had a law that was enacted by Parliament or a Supreme Court judgment or not. In India, we have a body of law that's built up through decisions given by courts over the years, and the right to refuse medical treatment is recognized as something which is called a common law right. So a right that's been developed by courts. Nevertheless, we have had some Supreme Court judgments that have dealt specifically with the question of whether there is a right to die. Some of this has been in the context of whether there is a right to commit suicide or not. And as a result of that, in 1996, in Gyankor versus Union of India, the court discussed whether there was the right to live with dignity up to the moment of natural death in the context of a right to commit suicide case. So the court held that there was no such right, but there was certainly a right to live with dignity. And that might ancillarily mean that there was a right to withhold or withdraw treatment and allow the natural process of dying to take over. Then in 2011 was the first time the court really grappled with a live case involving a patient in very tragic circumstances and involving complex legal issues of whether a person has legal capacity, whether a person who can be said to be the guardian of a person to take healthcare decisions on their behalf. And most importantly, for our purposes, who can decide whether or, can you withhold or withdraw life-sustaining treatment when the patient doesn't have the capacity to refuse? So if the patient had that capacity, there was no question that's common law right already existed. But if the patient lacks that capacity, what is to be done in those instances and what kind of standard should be applied? So this was the first time the court said that even when the patient has lost decision-making capacity, there may be instances where life-sustaining treatment may be withheld or withdrawn. This had to go through a particular process that the court laid down. You had to approach the High Court, wherever you lived or wherever the hospital was situated. And the High Court had to then give its opinion after consulting some experts and give its legal sanction to the withholding or withdrawal of treatment. So obviously, it was a very cumbersome process. And, because the case was such a unique and, sad one, that I don't think the legal effect of what this case was saying was felt in medical practice for a long time, because as far as I know, and I'm sure as your experience also tells you, it's not as if high courts were approached to allow life-sustaining treatment to be withheld or withdrawn. So the practice continued, the law prescribed a procedure, practice continued in its own way, but there was some legal ambiguity about what was allowed or not. This was then followed by, again, a very landmark constitution bench judgment where the Supreme Court said that the right to refuse medical treatment is not just a question of the right to die with the right to dignity, but also the right to privacy. And then this ultimately laid the foundation for a judgment which I'm sure all of you are familiar with, case of Common Cause versus Union of India, where Common Cause went to court asking the Supreme Court to grant legal recognition to advanced medical directives. So, you must note that up until then, advanced medical directives weren't even recognized as legally valid documents. In fact, Law Commission reports one Law Commission report had recommended that they not be recognized as such. And there was a bill that Parliament had that had been introduced in Parliament as well, where it was decided that these were documents that should not be given legal effect to. So Common Cause changed the landscape by allowing the legal recognition of advanced medical directives and also stating very clearly and categorically that life-sustaining treatment could be withheld or withdrawn, but prescribing a detailed set of complicated guidelines to govern that withholding or withdrawal, which proved to be unworkable in practice. And that's when Dr. Mani and the Indian Society of Critical Care Medicine decided to pursue an application in court that would modify these guidelines. And, we had the privilege of being associated with that. And, Dr. Mani and I were in court fielding the court's questions about how these guidelines should be modified and how could they be modified and made workable while at the same time safeguarding the rights of patients and concerns about, their misuse by doctors who might be unethical. So I'm giving you a flavor of what some of the the sense of the court was when we were having these discussions, because I think it's important for doctors not just to know what the law says and what they should do to ensure that there is no legal liability that is that they attract, but they must also have a sense of how society and how the law views them. So this actually from the court, it was quite evident that there was some discomfort about allowing the medical profession to perform this kind of function. I mean, and that may be partly because the judiciary is not educated about these issues and didn't quite understand what was at play over here. But it was evident that there was some deep distrust of the medical profession. So I think it makes it all the more important to, continue to do the right and ethical thing to allay this misconception or, as I see it, and because the kind of people that I have to interact with always give me faith in how the medical profession functions. But nevertheless, I think it's important to have this context to know that there's a very important responsibility that doctors bear when they perform this role in providing palliative care and taking these end-of-life care decisions. So some key legal points to remember from the court decision were that there is no right to die. There's only a right to die with dignity. That doesn't mean that the provision of opioid medication to alleviate pain and suffering is illegal in any way. It's well recognized that that is an integral part of providing medicine and treatment. However, the abetment of suicide continues to remain a crime. So in India, unlike in other Western countries, medically assisted aid in dying is not legal and will at some point require legislative intervention. there were also some other problems with the court's judgment in its use of the term passive euthanasia for withholding and withdrawal of life-sustaining treatment. So again, perhaps something to remember when talking about this issue, because to use the right terms, because the way in which this is spoken about plays a huge role in how the issue is perceived and what it is seen as acceptable for doctors to do or not to do. There were more complex issues like shared decision making that were difficult for the court to grapple with. So if you will read the guidelines, which I will take you through, you will see that the procedure that's described is very linear, whereas what Dr. Rajani and Dr. Mani were talking about involved a much more fluid back and forth conversation between patients, their families, and several rounds of discussion. But if you read the court's guidelines, you'll feel, oh, I have to have this discussion, get a sign off, move on to the next step, and finish it. And that's not quite how it works in practice, but that doesn't mean that the essence of what the court is saying cannot be incorporated in the good practice that Dr. Rajani and Dr. Mani were mentioning. And as you will see, there's a limited conception of patient autonomy, and that may be well founded perhaps in Indian circumstances where there are a lot of relational issues to take care of. Maybe autonomy in India is not seen or viewed in the same way as it is in the West, and it is not, at least in the court's judgment, even having a valid advance medical directive is not seen as being the be all and end all about decisions about withholding and withdrawal. So there is still, the opinion of the medical team that's required. There is still the opinion of or consent of the surrogate decision maker that's required. I'm maybe jumping the gun a little bit over here, but I'll come to that now when I take you through what the court's guidelines say. So I've just prepared a table here that compares what the 2018 guidelines prescribed, both for, and please remember that this applies both to withholding and withdrawal where a valid advance medical directive exists, as well as those instances where it does not. So as you will see, there are some key differences that have now been introduced by the court's January 2023 order. In the first, advanced medical directives in the earlier judgment had to be executed by a magistrate of the first class. Now they can be executed before a notary or gazetted officer. Everyone has had some experience with notarizing documents, so hopefully this should not be such a barrier any longer. The other two steps that have been changed are the compositions of the two boards that the court has suggested have to sign off on any decision on withholding or withdrawal. So earlier, this decision had to be taken by a medical board that comprised 3 doctors and the head of the department and 3 other doctors with experience of 20 years. Now this has been changed to the treating physician and any 2 subject experts with at least 5 years experience. The second step that's been changed, and this we think was an important one, in the earlier judgment, it involved bureaucratic involvement, because you had to have a board that was set up by a collector and have the district chief medical officer and again 3 other experts with 20 years experience. That has now been changed to a secondary board to be set up by the hospital only, and to comprise 1 practitioner nominated by the chief medical officer and 2 subject experts who are not part of the primary board. So just to give you a sense of how we think that this can play out in practice, it could well be the case that all the doctors in both the boards come from the same institution. So especially with the second one, what we are also in the process of developing at the moment is a way in which district chief medical officers can invite applications for nomination from hospitals. So if the district CMOs were able to do this, invite applications, publish a list of nominated medical practitioners, then hospitals would be able to choose from anyone on that list. So it could absolutely include a medical practitioner from your own hospital who has been appropriately nominated by the CMO. So it's entirely possible for, especially I think for larger institutions, to be able to make this almost an in-house process, and then therefore that really shouldn't prove to be as much of a barrier as the earlier judgment was. And finally, the biggest stumbling block, at least in my opinion, earlier the 2018 judgment required the judicial magistrate to visit the hospital and sign off on this withholding or withdrawal. Now all that's required is that you intimate the hospital, you intimate the magistrate about the decision that you've taken to withhold or withdraw life-sustaining treatment. So in short, this is the gist of what has happened. There are still some steps to be taken before these guidelines can be operationalized. Not before they can be operationalized, but for doctors and hospitals to have a clear sense of how to proceed with this. And I think the biggest thing there is to ensure that the district's CMOs are able to nominate the appropriate medical practitioners. So it would be advisable for hospitals to begin this process of their own accord, to initiate this process of nomination with whoever the relevant district CMO is in their jurisdiction. There are also some additional things that the judgment says about how advanced medical directives have to be stored with an authority or officer nominated by the local government, so either municipal corporation or its equivalent. And again, as citizens begin to be more active and exercise their rights in making these advanced directives, so also government will have to respond and nominate these officers at local authorities to act as custodians of these documents. There may be different kinds of issues that arise. There are lots of questions that people have about how this is, going to play out in practice. I won't go through all of them now because I'm aware that we have only 15 minutes left. So, we can keep these questions here on the screen in case anyone would like me to take up some of them. And in the meantime, I'm happy to, I'm sure Dr. Rajani and Dr. Mani are also all happy to answer any other questions that people might have. So yeah, here's just a primer on, what are the next steps perhaps for hospitals to do. So to develop SOPs along the lines that Dr. Mani and Dr. Rajani already mentioned. We should get districts' chief medical officers to nominate doctors. One suggestion has been that perhaps doctors who are already a part of committees to determine brainstem death under the Transplantation of Human Organs and Tissues Act can also form a part of the committees or boards for this purpose. And personally, for me as a lawyer and researcher and person who's generally passionate about this issue now, I would love to hear from doctors about what their difficulties and experiences continue to be with implementing these directives. So, we can continue to build evidence for the ultimate goal, which I think is having a comprehensive legislation on end-of-life care. So I'll stop there. I'll stop my slide at the questions in case anyone wants me to take them up. And I'll send this back to Dr. Sridevi to moderate the discussion.
I think there are a few questions already in the chat.
Okay.
Do we need to have a video counseling in such case a family member denies later regarding the procedural information?
I can't hear you very clearly, Dr. Sridevi. Do we need to have?
Do we need to have a video counseling in case family members denies later regarding the procedural information?
I don't think. Sorry, go ahead, Dr. Please.
So on, in a lot of ICUs these days, the counseling room has video facility that's there. It really depends on how the communication is. I think, Dr. Rajmani mentioned about communication is critical. And we all understand when a patient's family members are following us along when we're talking about the prognosis of a patient and the options that are there.
Dhvani, can you unshare?
Oh, sorry. Yes, of course.
So I think it's very important. This is one of those things that all of us know, that when you have consensus, everyone is on the same page. You don't need to be in a in the environment of mistrust. You still need to document. If you have any kind of conflict, or if you're sensing some kind of discomfort in the patient and their family, you may choose to document it with video counseling. In high risk situations or patients who are not known to the system, right? You get a patient who's coming transferred from another hospital, maybe has been to 2 other hospitals. It's a slightly complicated situation. Maybe you want to document it like that. But if it's a patient I've been seeing for 8 years and I have a relationship with the family, they get admitted to the ICU in my hospital, I don't think you will end up facing conflict in that. So it's always when it's a new patient, when it is something sudden, when most patients who have conflict in such situations, I think one important thing to keep in mind is trauma-informed care. If they've had bad experiences at other hospitals, they will come to you with mistrust. You know what Dr. Dhvani said about she's met healthcare professionals who have always, she's had a sense of trusting them. But we've all experienced patients and families who come to us, and we label them, we call them the chidchidi patient, the demanding patient, whatever. Why have they become like that? Because somewhere down the line in the past, the system has not treated them well. So they come to you with mistrust. If that's a situation, then you might want to document with very detailed, like who is there in the counseling, what were the topics discussed, and whether you want to have video counseling or no. That's only if you think you're going to land up in a conflict situation of complaint. That's Dr. Mani, your thoughts on that?
You see, there is a chat box question. There's somebody with advanced COPD and TB. Now, where do you draw the line? You see, that is the moot point. As a clinician, you got to prognosticate, isn't it? You got to judge. So there is 2 aspects to a judgment. One is objective, another is subjective. All right, medicine is science and art, as exemplified by this. So you need subjective, objective assessment. Objective, we got plenty of guidance in the form of scoring systems, in the form of the disease trajectory, right? So majority of the times, you get a fair idea of where it is going. Now you add the subjectivity. Where does the subjectivity come? It comes from patient values, wishes, patient story, right? Don't you integrate that? You take a history, don't you? You don't just look at the monitor. So patient story, patient's context, you combine the 2. Unilateral decisions are not good for this because there is always a possibility of being a bit wrong. Either you underestimate or overestimate. That's why everybody, now the ethicists, as well as the clinicians, as well as the law is saying, please don't make a unilateral decision. We combine it with other professionals. Take their inputs. Take specialist consult. If you're an internist, take the pulmonologist opinion here. Right? So you have a system of consulting and an iterative process by which you get to know, if not today, you will know by the end of the week, right? That is where we are heading. You have a theory, you have a hypothesis, this is going nowhere. But after 3-4 days, either your theory is shown to be right or wrong. So you integrate that. So it's a considered, deliberate, and a collegiate decision when the game is up. If you have TB, you have a reversible element, but combined with a very advanced COPD, which doesn't have a reversible element as a certain point, then you can get to know what is happening. So that is where, and then once you know it, and you have a consensus within the team, share it with the family, frankly, unambiguously, authoritatively. Right, that's the point from where you can develop what to do and a decision.
There was another question here also about elaborating on the role of palliative care in sudden advanced illness. So I can give you a simple example that we've all probably experienced is, when you have a patient who comes in with a catastrophic situation like a road traffic accident with traumatic brain injury or an aneurysm and some kind of an intracranial bleed, and then you are you think this patient might be approaching brain death, and you're in the midst of evaluating the patient for that. At this point, the patient is not feeling distress. However, the patient's family is experiencing a lot of distress. So in some of the ICUs in cities across India, we are now starting to see the role of grief counselors. When there is anticipated death of a patient in the ICU, you know that we've reached a point of no return. Whether the patient is going to go on to, especially if the patient is a potential organ donor, where the family is considering that, they do bring in grief counselors in many hospitals and many cities. As I said, these are limited resources, but as a medical community, we have to start thinking of ways of accessing these resources through telemedicine, because it's a huge, it's a very big, it's a big gap in our current system. But when there is a sudden change, so this you see in pregnant patient delivers, has a massive catastrophic event happen, and then there you were in the middle of what was supposed to be the most joyous event, the birth of a baby, and you're potentially looking at death of one or two of those. So in those type of situations, which is sudden, rapidly advancing critical illness with impending death, there's a major role in palliative care for the caregivers. Also, at that time, for the caregivers, for them to feel that my loved one is not suffering pain. If they see them in distress, then you have to reassure them that I'm giving them medication so that they are not in pain, that they are not in distress. The fact that they know that you're looking out for that, that's very important.
Any other questions from the participants?
I think someone has just asked one. So maybe I'll just read it out. And if the patient and family members have different opinions on end of life care and withdrawal of life support, especially we have many such requests from family members of patients in ICU during COVID time. Please give your view on this issue and associated legal implications. So, Dr. Mani, do you want to give your experience of what you do in such situations, and then maybe I can talk about what the law says on this?
So if you say that the family members have different opinions, that is, different members of the family have different take on the situation, isn't it?
Or
That's
is
what
it that the patient has one opinion and the family member has another?
that both are possible.
Ah.
If the patient may have an opinion, family may have another opinion, that is relatively easier. Then I would definitely honor the patient. That is very clear in law.
Yeah.
But when the patient is incapacitated and conflict within the family, then we have to work through the conflict. There is no ready-made answers. Please, we got to cook the meal ourselves. Nobody is going to hand it out to you on a platter. If there are differences of opinion, some people have reservations, you have to sit them down, ask them what reservation they have. Elicit their pain, their concern, their worry. Bring it out. Address it bravely. For heaven's sake, without courage, we cannot do anything, right? And you cannot take an end-of-life decision without taking it head-on, with courage and care and compassion combined. If you talk to them, their reservations may drop. Or if they don't drop, you wait a bit. If not today, 2 days later, the same family member may come, no, I thought about it, doctor, you're right, doctor. Or they may not even say you're right, pride may not allow it. They may say, can we think of something else? So you pick up the clues, then set your own rigid opinions aside, give them a hearing. You may feel that this is going nowhere, patient ought not to be on a ventilator. That's your feeling, your thought. You may be a very bright egg, but that is still has to be agreed upon by the family. So this we have to understand. We've got to reduce this power game. It's very important to stop this power gradient. I know more, I know better, I'm wiser, that doesn't work. And that's what the law is saying as well. It should be a shared decision. This is the worry of the law and of the public. We may bulldoze our opinion, bulldoze our expertise, convert it into a advantage. No, you can't weaponize it. It is meant to be for caring. So sit down, talk, negotiate, take little steps. If you can't take a big step, take little steps. Okay, if you can't do withdrawal, take DNAR decision. Withdraw antibiotic. That's such a big problem for you. You've got an addiction to writing antibiotics. So you work on that addiction and remove antibiotic, remove transfusion, remove daily X-rays. So you work on these little things, then you get more, you gather momentum, you gather courage, and the family knows that you're walking the talk. Family knows you're caring because you're talking. It makes all the difference. That conversation, that's why I had many slides on conversation. That is the weapon. That is the intervention, which is not being highlighted enough. What do you say, Rajani?
Absolutely, sir.
You're
I
big on
think
this.
I'm now really like in your talk today. There's one part that I'm going to use again and again. I'm telling you right now, I'm stealing the concept because I've always said that communication is a procedure, and you gave a beautiful insight that sometimes you're trying to do a central line and it's not coming because it's like slightly different anatomy or something. Sometimes you may have to take a break and come back to the procedure again. Sometimes you may have to ask one of your colleagues, can you come and do it? I'm finding this one difficult. So you lean, and it's not the conversation about withdrawal, withholding life-sustaining treatment or limitation of life-sustaining treatment is not a one-shot conversation. Sometimes it's done in series of steps. Great example as that you shared with us. There's one more question over here.
Rajni, I'll just answer the legal
Yeah,
part of
the legal
earlier
part of
question.
this. Yes.
Yeah, so very briefly now, if someone has a valid advance medical directive and they've mentioned a surrogate decision maker there, then that person's consent is the one that needs to be taken. So you don't need to worry about deferring family members' opinions. If that doesn't exist, and if that's likely to be the case in most instances, then the strategy suggested by Dr. Mani is the right one, because Indian law doesn't have a clear answer for who your guardian or your next of kin or next friend is. That simply doesn't exist anywhere. And if you've been following some of the arguments in the right to marriage, the marriage equality case, you will see that the court is grappling with exactly this question. They don't know who the next of kin is supposed to be. So in that case, the way to do this is through this kind of negotiation and conversation. If there is intractable difference of opinion, then don't implement don't pull the trigger, don't withhold or withdraw.
Discontinue life support, yes.
Yeah.
I want to say one more thing over here, which maybe we didn't speak about as much, the choosing wisely guidelines and things like that. Also about the right to not offer any non-beneficial treatment or to refuse when a patient's family asks you to do something which is non-beneficial. So if a patient's family is asking you to give transfusions or put somebody on ECMO, but it is not indicated or is not going to be a life-saving or beneficial, you are not obliged to do that. That's one point. The second was about the documentation of DNR in the chart. That question had come up in the chat box. I think if we know that a patient has had a chronic advancing illness, then cardiopulmonary resuscitation is not a beneficial thing for them for any quality of life or survival or anything. So we don't even need to offer it to them as a good medical intervention. It is not something that is helpful. It is non-beneficial. So when we document this DNR status in the chart, I prefer to use the family agrees that no invasive, non-beneficial treatments. Agrees with me. It is my medical opinion. This patient does not need CPR. CPR would be a burden, would be traumatic, would be distressing, most definitely not beneficial. Instead, the wording we write as family does not want CPR. Now, if I am the family member signing that document, you have given me a gift of guilt for the rest of my life for signing away my loved one's life. I did not do everything, right? What you need to give them a sense of is you are doing everything perfectly right for your loved one for their end of life. So I feel strongly about this, so I'm saying this. Don't write family does not want. Family does not want ICU. Family wants ICU but does not want CPR. whose family to want? We are doctors, we are advising them, we are doing shared decision making after explaining to them the pros and cons of it.
See, a take on this, Rajni, they also write very often in the case of family wants everything done. Okay, so you put everything on the family. See, family what is everything in life, you know? Can you define everything?
Family want
So
to
that you see, then if somebody says, I want everything done, I will sit down and ask that person, what do you mean by everything? Can you let me know? You know, in this context, then they open up. And majority of time, by everything, they mean caring. They don't mean intracardiac defibrillator, something like that. Okay, so they don't even know about it. So they generically tell you. So you just latch onto it and then you keep pumping the chest or do the. That's not fair, right? That is just hiding behind these just mere form. We are not here to just go through the motions of form. Here we are here to do what best you can as a caregiver with integrity. And if you just sign a form, want everything, don't want, what is that? Is it caregiving? Not at all. It's just the opposite. If you're just wanting only the form, not the spirit, then you're not caregiving. So I like what Rajni said. You can simply write, patient, we have discussed the issues of non-beneficial treatment, and the family is very clear, they don't want non-beneficial treatment. Since CPR is a medical intervention, you're not obliged to prescribe a medical. See, this is one view, Rajni, but this is not always the view. See, now there is a legislation law in the US that you've got to discuss CPR before you write the code. Okay. This law is also there to some extent in the UK in certain circumstances. It's identified 5 different circumstances. When there is clear futility, you don't have to do that. But when there are gray areas, you're not obliged to give CPR when you don't believe in it, but merely you're obliged to inform. You're obliged to discuss out of respect to autonomy.
Yes.
Right, as an ethical principle.
Yeah.
Not as a medical obligation. So there are 2 different things. So as far as possible, I follow this.
Yeah. We
I don't
discuss
write a
it and then
DNAR order without having discussed the issue. Although I have a right, I know. I don't believe in CPR. I can tell my resident not to do CPR. That I think I can defend in court. But
absolutely,
you see,
sir. Very,
but
very
if the
important.
court says, why did you not be kind enough to discuss this? Then I'll feel shamefaced because I have to be kind enough. So you see, the most important value in all this is kindness. See what I mean? There are 3 things identified in a good end of life quality assessment. Okay, one is the pain and symptom control, which I discussed at length. Okay? Number 2 is having conveniences for the family in the ICU, in the building. Right. And number 3 is kindness, whether you've been remembered as a kind doctor. Right?
There's one more question here which says, is it mandatory that a patient can be put to end of life care status only after a board certifying the same?
No, I don't think the status has to be certified by a board. What this procedure says is that the actual withdrawal now has to follow this process. But you can, as a treating team, decide that this medical treatment is no longer beneficial for this patient, and that opinion doesn't need a certification. It's the action of withdrawal that needs that certification.
You know, Dhvani, as I was mentally preparing for this session today, one thought occurred to me, which I'll lob it here.
Yeah.
Okay. In a situation like this, when there is no obligation to provide a medical treatment, why do we need to go through these 2 boards?
Yeah.
See, in two situations, you don't need to go through this board. When it is very clear medically, it is not a standard of care. And number two, when there is refusal by the patient. Now, which is a procedure
Yeah, that absolutely.
which will require you, over and above the consent
Agreed.
to go through these two boards. So see, so you will find that quite a substantial proportion of these cases, you don't have to go through this board.
Correct.
Okay, I didn't want to say that in court.
think
They'll get wised up. But
to
in
answer
practice,
this-
on the ground, this is what it is. Majority of these cases really are a refusal of consent business.
Yeah.
I'm legal, and
Yeah.
I don't want to bother myself and the family through unnecessary procedure.
I think so to clarify, when everyone is in consensus, you never have to jump through any of these hoops. Why was this all done? Think about it as, because we don't have this priority of who is the next of kin, spouse, parent, child. If there could be 4 adults fighting over what's the right decision for this person. And as we said earlier, Dhvani had addressed the part about the patient has a stated wish. And there is a lack of consensus amongst the adult immediate next of kin. And that's when you would have to go through the entire you'd have to go through all the steps. When you have consensus, there's never a problem. Just document it well, document it really well. So when I do my family meetings, I write the names of each person present and their phone number when I'm writing it down in the...
Unfortunately, Rajani, this is not the court's position.
Yeah, I know it isn't. I know it isn't the court's position.
But
it's what we do in practice. It's what we do in practice.
On the ground, when you peg it on the refusal of consent thing, okay, I cannot intubate if there's a refusal of consent.
Yeah.
For that, how should I go through 2 boards?
That's absolutely, doctor.
Yeah.
So you see, that's what I'm saying. Majority of times, this is what I have done in practice.
Yeah.
I have informed them enough for them to refuse something. That's it. Simple. Keep it simple. Refuse. Refusal is allowed. That is what whole consent process is. And there is no law to overrule refusal of consent.
Dr. Suresh Kumar asks, is there any teleconsultation facility available for doctors who are taking care of end-of-life care? I know Pallium India has a directory of palliative care consultants and departments all across India. I would suggest to everyone who's on this course, connect with the palliative medicine community in your city, town, wherever you are, so that they're available to you for access for advice on cases.
You see, I've had a lot of people calling me from various parts of India for actual clinical situations on the ground. And sometimes I have been put on loudspeaker for a group of doctors and in that family meeting. So this is possible. So whoever you think will be able to help you, you connect. That's it. We must do the job.
I think there are no more questions. Just added that we have telehealth facility available for professionals, not just for patients. You can call us, and if needed, we'll transfer the call to experts if you want to hear from them also. So that's something that you can make use. I'll share the number of the telehealth in the WhatsApp group that we have, so you can use it. Thank you so much, everyone, for this session. Thank you, Rajani. Thank you so much, Rajani, for rushing back from hospital and logging in.
Thank you, Rajalakshmi. Thank you, fellow panelists. Thank you, audience.
Thank you. Thank you, Dr. Sridevi and Pallium. Thank you, Rajalakshmi, all the people enrolled in this program. Dr. Mani, Dhvani, I always learn something new to carry forward in my practice when I listen to you. So thank you.
See you all for another session, probably the last session next week. Thank you so much.
Bye-bye.
Thank you all. Bye.